would like to invite our Principal Secretary, Mr. Sampath Kumar, to just talk about this case, which is very prevalent in Meghalaya, on an adaptive challenge and how do we think about it in technical terms or in adaptive terms.
I think a lot of colleagues from health department, they understand this one. But I want to tell you one astonishing, shocking thing that has happened to the state. In 2005, the government of India has launched National Rural Health Mission. And when it launched, one of the ideas was that, we need to promote institutional delivery for ensuring safe delivery. When it was launched, because this was instructions, so what people, at that point of time, they felt was, no, I think we need to encourage institutional delivery. So earlier, these deliveries used to happen both at institution, but also at the house with the help of traditional birth attendants. We call dais or something. And we stopped training these traditional birth attendants since 2005 in the state. Though more than 50% of our births are handled by the traditional birth attendants. Imagine, no wonder actually there is so much maternal mortality and so much neonatal mortality. The reason is that we felt, I think the best way to ensure safe delivery is, institution delivery, and we should follow that one. But what is the purpose? The purpose, as our Chief Minister has very nicely mentioned, what is our purpose? Purpose of, laying a irrigation canal is essentially to see that, we actually produce some good crop. Similarly, the purpose of entire our healthcare work is to save lives. So, in a geographical setting, so whether this decision is, banning the traditional birth attendants or not supporting them. Earlier, traditional birth attendants are used to be given them safe delivery kits, everything. So, I think in this, maybe to understand, that's where when we look at the problems, are we looking at these elements, is it something that purpose is actually, whether purpose, are we achieving the purpose through the technical approach? Or is there any other approach through which actually we can achieve the purpose? I think these questions, definitely we need to ask. So that's why technical solutions are important, definitely important. You require to have oxytocin so that there is no postpartum hemorrhage when there is a case of a bleeding. I'm not saying that one. But at the same time, what is when you have such a dispersed population where our people live in 6,400 villages, sometimes it's so difficult. In fact, I can see Dr. Shakina, the other day I went to her district. There is a pregnant mother, high-risk pregnant mother. They have to go and bring her from almost 4 hours she has to walk. And then take her to a vehicle and bring her to the hospital. So these are, some of the issues. But I request, maybe Dr. Yvonne, maybe we'd like to share what is the adaptive approach.
Thank you so much, sir. I'm Dr. Yvonne Sangma, District MCH Officer, West Karo Hills. Yes, as sir was mentioning about the NHM goals, that is to reduce the maternal mortality ratio, but and which we have been advocating to promote institutional delivery. But from 2006, now we are in 2022, and we have been struggling to do that. And we have to consider, as a doctor, I will say that yes, I will not encourage the traditional birth attendants to conduct a delivery. I need all deliveries to be conducted by a doctor or a skilled birth attendant. But in reality, we have to accept the fact that the distribution of the villages, the availability of the resources, the human resource, doctor population ratio, A&M population ratio, the difficult terrains, the inaccessibility. So what happened of that, in spite of the NHM coming in 2005-06, we are still was struggling with maternal deaths. So what happened, I think during the COVID time, when we had Sir Sampath used to have our rescue mission reviews during every week. So that was the time when we felt the need again that mothers are still delivering at home. in my district, I have around 14,000 deliveries a year, of which only 52% deliveries are happening in the institute, whether it's a subcenter, PHCs, dispensaries, or at the district hospital, keeping in view all the other factors. Also, social factors like poverty, illiteracy, cultural practices, inaccessibility. And 48% of the 48% of the deliveries was conducted by the traditional birth attendants, which has been there for years and years. So what Sir has suggested us and what we have done, Sir was saying about the last traditional birth attendants, yes, that we did, I think most probably in the year 2010, that was the last TBA training which we did. And we used to supply them with the cord tie, the blades and all. But that was stopped by the government of India. So what we did in 2020 was that since for 58%, 98% of the deliveries of this 48 was conducted by the traditional birth attendants, only 2%, imagine, only 2% by our skilled birth attendants, ANMs, because they cannot reach. They have so many work load. So we have in 2020, I have nearly 2,000 traditional birth attendants in West Karo Hills. That is a fact and a reality, of which around 1,200 we have trained them in the month of July 2020. Now, we are not saying that we are encouraging the TBAs to conduct the deliveries. What we have done in the training is that we have called them, we have trained them on the danger signs of when, what to identify and what to do. If in case they have to conduct the delivery, how to do it, how to conduct a safe delivery. But most importantly, identify the danger signs and bring to the facility. Because we have to accept that whether we want it or not, they are the ones conducting delivery at home and they are acceptable to the people. So I think even though technically we say no, but practically in reality, yes, we still have to rely on the TBAs. We are not going to encourage them. We are telling them about the danger signs. I can even cite one example. I had one example in Salsala when I have trained the TBAs on this. Immediately, there was one case under Jeldupara in a hard-to-reach village. One delivery happened around midnight. And it was a very hard-to-reach area. The placenta did not get expelled by Havana. So immediately this time, the traditional birth attendant understood, yes, this is a time that I cannot keep the mother anymore. I have to immediately refer the case to a hospital. So the TBA convinced the family members to immediately refer the patient to Salsala CHC. But since the area was very far off and it took them nearly 2.5 hours in auto, even to get an auto was very difficult, but unfortunately we lost the mother. So what we're trying to bring the point here is that we do not encourage TBAs to deliver, but in case they deliver, when the families do not bring the mothers, when they want when they want a delivery at the place in the comfort of their homes, we have to also train the TBAs on conducting safe delivery. So that's all I want to say. Thank you.
Any others would like to share? Dr. Shakina or Dr. Helen?
Yes, with regards to the technical fix, I agree with my colleague. I mean, it's not always simple as 2 + 2 = 4. You know, we have to have a different approach. And our Deputy Commissioner, when we had our meeting after the in-depth review, he had discussed and he says, why? Why exactly do these people deliver at home? When we identified that, you know, the people are, most of the maternal deaths happen because they deliver at home. They want to increase institutional deliveries. We thought we'll identify why. And 70% of those home deliveries were because they want to deliver at home. You know, to them, that was the preferred method of delivery. But the others, they did want to go to the hospitals because they had complications or they knew that they were high risk. But then amongst them also, there was another quite a significant percentage that actually could not access. Yeah, they could not access. They reached the health institution, but there were no beds in the health institution. They had to go back. Go back because they could not afford to go to a private institution. So that like defeats the purpose, right? When and just recently I realized that we have a lot of women who are due, who have been identified as high risk. That is around 240 of them for 30 beds in our district hospital. I mean, what are we trying to do? You know, like send them all to go and stand in line and then lie down, lie down in the corridors waiting to deliver. I mean, waiting for a bed to free up. So I think we need a different approach.
Thank you very much. And I think both those examples really do illustrate how this complication of both technical and adaptive, maybe you could say technical on the one hand is the lack of beds, but adaptive on the other hand is also people's values and what they're comfortable with, and what can you persuade, say, a TBA to work with you, and how do you go about doing that? How do you go about persuading the community? So that's an example from health, and I'm sure that for all of the other sectors that you all are working in, you can think of many examples of this kind. And the reason we wanted to start there before turning to PDIA is because when especially we're looking at these complex problems that have adaptive components as well as technical components, this is where in particular the PDIA methodology was sort of designed to come into play.